Well, hello everyone, and happy St. Patrick's Day. Thanks for joining. Just a couple of standard announcements before we start. We will take about 10 to 15 minutes to go through a few slides introducing the concept of fertility preservation during survivorship, and then about 30 minutes answering questions that were sent in. Finally, we'll have about 5 to 10 minutes to answer any additional questions, so please feel free to put those in the chat, or you can unmute yourself and ask them at that time. We do appreciate that your mic to be muted and camera off throughout the webinar until the end part for questions. This will be recorded and available on YouTube. If you have any questions, please post them again at the end of the chat, and we hope to have some time. And we will also share our email addresses so you can reach out via email too if there's any additional questions that you have that weren't answered. And thank you for those who sent in questions. So we're going to start. So I don't know if Joe, but we can start with the introductions first. So you are tuning into Pediatric Cancer Survivorship and Oncofertility and an overview and panel discussion. Let's see. Hopefully let's see. Sorry, technical difficulties. Okay. So this is welcome from our panelists. And just to introduce myself, my name is Dr. Allison Close. I'm a pediatric oncologist at Helen DeVos Children's Hospital in Grand Rapids, Michigan. And I will be moderating this session. I am the current vice chair of the PAC. So, and I'm happy to, again, answer any questions at the end too. So, we are really excited for this presentation. So our first panelist is Dr. Pinki Prasad, and she received her Bachelor's of Science in Biology from the University of California, Riverside. Following this, she attended the American University of the Caribbean in St. Martin. She then pursued a Master's in Public Health at Vanderbilt University. She completed her Hematology Oncology Fellowship at completed her Hematology Oncology Fellowship at Vanderbilt University. Throughout her career, she has focused on long-term health outcomes of pediatric and adolescent and young adult cancer survivors. Her commitment to this field continued to grow during her tenure as Assistant Professor of Pediatrics at Louisiana State University Health Sciences Center, where she established the first and only multidisciplinary clinic dedicated to the care of pediatric and AYA cancer survivors. She has also been involved in several significant projects. She served as a co-investigator for a multi-center study titled Distress in Pediatric Oncology Setting, Intervention versus Natural Adaptation, which began on January 1st, 2020 and is ongoing. This study evaluates the impact of an animatronic duck in reducing distress among pediatric cancer patients. Additionally, she is a principal investigator for the St. Baldrick's Infrastructure Grant since January 1st, 2022. She's utilized grant funding to hire clinical research coordinator and to open more clinical trials for the AYA population. She is the principal investigator for an Alliance pilot grant aiming to improve oncofertility care and referrals through implementation of a risk stratification system for AYA patients at NCORE MU. Our next panelist is Dr. Joe Letourneau. He received his bachelor's degree from the University of Michigan and a medical degree from University of California, San Francisco School of Medicine. He completed OB/GYN residency at the University of North Carolina, Chapel Hill, and fellowship in REI at UCSF. He is currently assistant professor of reproductive endocrinology and infertility at the University of Utah, where, in addition to providing expert infertility care, he also serves as a co-director for the University of Utah's Oncofertility program. The University of Utah's Oncofertility Clinic serves as a referral center for the United States Intermountain West region, including cities and rural areas in Utah, Nevada, Idaho, Montana, Wyoming, and Western Colorado, and Northern Arizona. That's a lot of places. He has published more than 80 research articles and abstracts in the field of infertility and is internationally recognized as an expert in fertility for cancer survivors. He has worked to ensure more universal insurance coverage for oncofertility services, including recently helping to make Utah the second state to cover oncofertility services under the state's Medicaid plan. He currently serves as the American Society of Clinical Oncology Fertility Preservation Guidelines Expert Panel, which establishes best practices around fertility cancer treatment, and has served as an expert panelist for the Food and Drug Administration regarding fertility concerns prior to oncologic drug approval. He is also the 2025 Oncofertility Consortium Chair Conference Co-Chair. And then finally we have Megan Pruett. She is a certified nurse practitioner at the Cancer Survivor and Fertility Preservation teams at Affleck Cancer and Blood Disorder Center of Children's Healthcare of Atlanta. She has been the endocrine nurse practitioner for nearly 20 years and began practicing with Affleck Cancer and Blood Disorder Center in 2017. She serves as a consulting provider for the fertility preservation team, as well as caring for oncology and hematology patients with endocrine disease and cancer survivors with endocrine late effects. So with that, I will let Pinki take it away.
Thanks so much, Allison. So I'm going to just do a few slides to kind of give you our key objectives. One is I'm going to try to help understand survivorship and explore the journey from diagnosis through long-term follow-up care. We're going to discuss a few late effects and how we identify potential long-term complications of pediatric cancer treatment. Obviously, this is a discussion about prioritizing fertility and learning why fertility preservation discussions should begin at diagnoses, but really should continue through survivorship care. And then we're going to look at some review strategies and examine evidence-based approaches to fertility preservation. And last but not least, answer some questions that were posed by the group. Next slide. So this is a diagram that shows that cancer survivorship journey starts at diagnoses. And so early discussion about long-term effects are really, really important. During the cancer treatment itself, we monitor for acute toxicities that may predict late effects. And then after treatment, the focus changes. And initially, there is surveillance for recurrence for disease, but that shift focuses to screening effects that's based on treatment exposures. Surveillance for late effects is based on risk-based approach, and the goal for pediatric and AYA cancer survivors is lifelong surveillance, and for our pediatric patients, transition to adult care becomes very important. Next slide. So what does survivorship after cancer care look like? We currently have almost 500,000 childhood cancer survivors in the United States, and though these patients have survived their cancer, they are at risk for late effects. Late effects are health problems that occur months or years after the cancer treatment has ended, and late effects in childhood cancer survivors affect many different organ systems, but specifically body and mind. There are three important factors that affect the risk of late effects. One is the chance of having late effects increases over time. So this is important for our survivors to know. Regular follow-up care is very important for survivors of childhood cancer, and good health habits are also important for survivors of childhood cancer. Next slide. So the goals of survivorship care are to help survivors lead the best life they can. As a survivorship physician, we tailor each visit based on different factors, and we risk stratify our patients. Assessment is based on treatment exposures. For pediatrics, we use guidelines to help with risk stratification. So we specifically use Children's Oncology Group guidelines. And for fertility, we continue to use the PINS risk stratification system that everyone's familiar with. Survivorship care is done in a specialized clinic that includes a multidisciplinary team that includes oncologists, endocrinologists, cardiologists, psychologists, and a comprehensive evaluation occurs annually. One of the goals is to provide education and support. So patients and families receive treatment summaries and survivorship care plans, and we actually discuss a lot of self-advocacy training. So as these patients transition to adult care, they have some of that information in hand. Next slide. So survivorship clinics, our survivorship clinic here in New Orleans is called Tackle. So it's a treatment after cancer and late effects. And it's a place that specializes in follow-up care for children and adolescent young adults who are treated for cancer. We have a multidisciplinary clinic that includes cardiology, endocrinology, fertility, nutrition, psychology, and pulmonology. They usually are either embedded in our clinic or they have visits scheduled for the same day. Our clinic starts seeing patients 2 years from the end of therapy or 5 years from diagnoses. And all of our patients receive a treatment plan or survivorship care plan. And this helps them monitor late effects and perform surveillance to look for late effects. It's also a document that helps if they transition care or if they move somewhere, kind of gives a blueprint of what needs to happen. And we do transition our patients between the ages of 22 to 25. Most of our patients are transitioned to either an adult oncologist if they still have surveillance that needs to be done for their primary disease, or they're transferred to a primary care provider. Next slide. So this is what a survivorship care plan looks like. We actually utilize Passport for Care that helps us tailor our plans. We input data about each patient's treatment, including the total doses of chemotherapy. And based on these exposures to chemotherapy, radiation, and surgery, we come up with recommended surveillance that you could see on your right-hand side. Next slide. So as most of us are aware, common late effects of pediatric cancer encompass many, many broad domains. And so simply there's a growth and development domain that we look for. Organ function is very important, including cardiac, endocrine, neurocognitive, and secondary cancers. We do discuss reproductive capacity at every visit, and we also discuss potential late effects to health of offspring. Late sequelae therapy for childhood cancer is anticipated, like we talked about, based on therapeutic exposures. But the magnitude of risk and the manifestations in every individual patient is influenced by lots of different factors. And so we do tailor all these visits very specifically to every patient. Next slide. So we're well aware here that there's a critical window for our patients for fertility preservation. This is usually done before treatment begins, but delays can eliminate preservation options. And so the treatment risks that we're well aware about are alkylating agents that can damage gonads, radiation to the pelvis, which affects reproductive organs, and surgery can also impact fertility. There's a lot of discussion about patient rights. All patients do deserve fertility information. Age-appropriate discussions are very essential and can be difficult for the pediatric population, and ethical approaches respect family values is very important. There is a psychological impact that we are well aware of. We know fertility concerns affect quality of life, especially after patients have survived their cancer. And there's a lot of studies that show that survivors report increased anxiety about reproductive potential, especially as they head into the survivorship atmosphere. Next slide. So for us, we at Children's Oncology Group, most pediatric and adolescent young adult programs utilize these survivorship guidelines. This one looks at the potential late effect of diminished ovarian reserve based on the therapeutic exposure of a classical alkylating agent. It's based on evidence. It's re-examined every 2 to 5 years. And these guidelines help with health counseling and further considerations. So for this potential late effect, some of the potential considerations for further testing and intervention can include testing FSH, estradiol, and AMH, including a consultation with the reproductive endocrinologist, who will also examine for antral follicle count and discuss ovarian reserve evaluation and consultation about potential fertility and interventions to preserve future fertility. Next slide. This slide actually discusses the potential late effects of impaired spermatogenesis due to alkylating agents. And very similarly to our previous one, there's a potential consideration for further testing and intervention. So for this one, for sexually mature patients who desire information about potential future fertility, we can conduct a semen analysis or once again, look for FSH inhibin B alternatives if they're unwilling to provide a semen analysis. Next slide. So I think the big thing is that, all of us are aware about fertility preservation options during or before chemotherapy begins, but what are the options during survivorship or after cancer therapy is over? And as the slide will show you, there aren't very many clinical trials or experimental options that are open for patients during survivorship. All the standard things that we think about, including sperm banking, testicular sperm extraction, are available for postpubertal males. For prepubertal females, there's really nothing that's standard. There are some discussions about whether ovarian tissue cryopreservation, even the survivorship world, should be an option. And then for postpubertal females, oocyte embryo cryopreservation is still an established option during survivorship. Next slide. And so how do we improve access to fertility preservation? There's lots of questions and options during survivorship. One, I think, is how do we incorporate some of this information into our EHRs? Almost all of us have EHRs. And so this will prompt electronic records. It'll prompt physicians to kind of think about these things pre-chemotherapy, but even post-chemotherapy. And some of these things that we're thinking about are automatic referrals that increase consultation rates to our endocrine fertility experts. There's also provider education. So how do we train our oncology teams, including the pediatric teams, about being more comfortable discussing oncofertility? Webinars and toolkits we know improve knowledge and confidence. And obviously research advances in vitro maturation of immature eggs. Is there artificial gametes from stem cells that are bioengineered gonadal tissue? And then the big one is obviously policy change needs to happen, insurance coverage with legislation, and just having national standards for fertility preservation access with equitable care initiatives that are important. Next slide. So we are happy to take questions, and we just want to thank everybody for the opportunity to discuss some of these things.
All right, thanks, Pinki. So next, we're going to go through questions that were sent in, and thank you for everyone who sent them in. So the first question is for Pinki and Joe, and the question is, for patients who had minimal risk therapy but request further testing with AMH, how do you counsel them regarding the need for fertility preservation with low AMH?
I can start. So I think it's, for us at our clinic here, our survivorship clinic, we do recommend getting a baseline hormone level, including AMH for all survivors at age 13. And then based on their PIN risk stratification, we make decisions about how we're going to follow these patients. So if they've undergone minimal risk therapy, we often will not repeat these labs unless there are issues with their initial labs, or if there's issues with them not reaching menarche or some other issues kind of coming up. But we do get baseline for all of our patients.
Yeah, I think it's important to remember that some people might have a low AMH unrelated to their cancer therapy. So something like 1% of women will go into menopause before 40, which can have a big impact on family building, of course, and that might be related to underlying biology. There's some supposition that early menopause and cancer may be linked in some cases. The DNA damage that results in cancer might also result in advanced or accelerated ovarian aging. So if I came across a patient with low ovarian reserve that also had low risk therapy, I would probably still be a little bit concerned about their long-term reproductive potential. Since egg freezing and embryo freezing are generally so safe, like if someone just walks into our office at the fertility clinic and says, I'd like to freeze my eggs or embryos, we more or less do that because it's such a low risk procedure in general. The main risk is the cost. So if someone were post-menarchal and interested to freeze eggs or embryos despite having low risk therapy, I might offer it to them. The challenge is that some people are born with a low egg count, kind of keep a low egg count for many decades and may never go into early menopause. So low egg counts don't predict fertility per se. They do predict how many eggs we might get from egg or embryo freezing. So in a sense, the earlier we freeze eggs or embryos, the better. Now, I wouldn't necessarily extend that to someone who's like 12 or 13 if they're not ready to make a decision. But if someone was, say, 24, it kind of makes sense to do sooner than later. So I think it's always an option to consider, even if the risk of therapy is low risk for gonatotoxicity. The other thing is AMH is a little bit dynamic, so it can go up slightly around menarche. So if someone was low and they were pretty young, I might just kind of trend it for a little while and see where it's going. Yeah.
And so if a patient came in with a low AMH and had moderate or significant level risk therapy, does that change your counseling about referral, Pinki? I know because obviously you're kind of on the front end, and then usually on the referral end, and then Joe is who we're referring to. So does that change when you would counsel a patient?
Yeah, we do. So if they had moderate or they're at increased risk or significantly level of increased risk based on the risk stratification system, we do actually refer to our endocrine, our fertility specialist. The problem always is when they're really, really young. So if they're like 13, 14, 15, we have a pretty frank discussion with the family, and then the family kind of helps make a decision. A lot of it is dictated, unfortunately, by insurance and things like that. And there's a big, huge cost associated with this. Plus, there's, I think, for a 14, 15, 16-year-old, there's a lot of psychological decisions that need to be made if they're going to start freezing their eggs. The discussion's much easier for 18 and above. I think I've had a lot of young females who receive this therapy when they're in their late or early teens, and they are very interested in oocyte preservation. I think the biggest barrier we've run into, unfortunately, has been cost. And so we do have a wonderful reproductive endocrinologist here who actually does a lot of pro bono work, but also does a lot of work for, he'll kind of come up with a payment plan that we've been able to refer our patients to. But we try to refer as many patients as possible to make sure that they have all the information they need to make a decision.
Thanks. Next question is for Megan and Pinki. How often do you follow AMH levels, and does it vary based on the therapy risk level, minimum versus significant versus high?
I think our practice is similar to kind of what Pinki said with the low risk girls. We may opt to not repeat immediately if their initial AMH is normal. It kind of depends also on the family's level of concern. So I think some families want to discuss this topic more frequently, and we might be following AMH every couple of years in the low risk patients in those families. I think if they're a higher risk individual, then we might do yearly AMHs or close, just watching, kind of waiting for them to be ready or be older, to kind of have some trends when we send them to REI.
Yeah, no, I think that we do the same thing as Megan. I think that it's a lot of it for our minimal risk patients. We really try not to repeat unless there are issues. That we have families that are very nervous and they want to know, and then we will make some decisions based on that. But if there's a big cycle change or there's something else that's changed, then we do tailor that response quite a bit.
This is not a question that was posed, but I have it. So do you follow anything else besides AMHs when you're monitoring these patients?
Yeah, I mean, we're probably getting an FSH and an estradiol with it just to have the whole picture, especially if it's something like clinical that has prompted our, cycle change or something like that. We usually repeat it all, not just.
Yeah, I mean, I think that for our baseline, we always do FSH, LH, estradiol, and AMH for our females. And then based on what the results are, we always call endocrinology and they ask us to repeat everything regardless. So we repeat everything.
I think sometimes the exception, I guess, is maybe like if we know the patient is definitely going to go to REI, then we wait because they want timed labs and we almost never can get timed labs. So that would be the exception. Just do it all.
I would say from the REI side, we mostly use AMH as the ovarian reserve marker. Where FSH can help us is if someone has very low ovarian reserve and they have like kind of a tonically high FSH, they might be less sensitive to our gonadotropins. So we can counsel them about that. It might adjust like the way that we do the stimulation. So if someone already has a really high FSH and we give just like bucket loads of FSH as injections, it's probably not going to make a whole lot of difference. So we can counsel people about different dosing regimens, which can make the approach a little bit less expensive. So sometimes we use actually kind of lower dose gonadotropins when people have really low ovarian reserve, because we're hoping we'll get 1 or 2 eggs anyhow, and they kind of make enough FSH in their brain to probably facilitate that anyway. The other point where it would probably be helpful from our perspective is if someone has delayed onset of menarche and we're trying to determine, okay, is it from, having no eggs left? So the AMH will help us determine that. But then is there some constitutional delay related to their disease status from cancer, in which case their FSH might be low along with a low estradiol. So yeah, sometimes you can add a little bit to the picture, but I would say mostly in terms of like the ovarian reserve effects, or the effects of chemo on ovarian reserve, mostly an AMH is okay. And then one little wrinkle to it that I'm sure y'all see, but if anyone's newer to sort of checking it frequently with patients is, I usually describe it as accurate but imprecise. I've seen a number of patients where like their AMH 1 year is 1.1 and the next year it's 0.9 and the next year it's 1. Basically it's going to be in the same sort of approximate range. And I would consider under 1 to be low, about 1 to 4 to be medium, and above 4 to be high, measured in sort of United States units. It's a little bit different in Europe. But basically, a lot of people are going to kind of hang out in a zone, and their level is going to bounce up and down a little bit in that zone. But if we don't counsel people about that, they might feel like going from 1.1 to 0.9 is a really big change, and it might just be like sort of assay-based differences. And if we checked it the next day, it might be 1.07 again. So I really encourage people not to make big decisions about, a few tenths of a percentage point of change, and try to find reassurance in the idea that it's probably, still in the same range or so.
And with that, actually, is there a specific AMH level or downward trajectory that you would want someone to always kind of think about putting in a referral to you?
Yeah, under 1, I would say is a good cutoff. So if the AMH is under 1, then that's low. If it sort of like jumps between brackets, so if it was above 4 and now it's 2, or if it was above 1 and now it's below 1, I think those would be great times to refer. If it goes from 2.7 to 2.3, as an example, you could consider rechecking it. I think we're always happy to talk and see patients, but yeah, a lot of times a few tenths of a percentage point, especially if it's not dropping below 1, is likely just variability from the assay being imprecise.
Okay, thanks.
Yeah.
I'll move on to the next question unless anyone has any other things to add to that discussion. Okay, so for patients who underwent high-risk therapy when prepubertal and may still be prepubertal at entrance into survivorship, how early would you consider oocyte cryo, for example, if they start puberty and menstruated on the early side, like 10 or 11? So I guess at what point, if they're prepubertal but got high-risk therapy, would you consider oocyte cryopreservation or referring once they start menstruating?
Yeah, I'm happy to take that if that's best. But I would say that we can really do oocyte cryo whenever someone has started menstruating. I think when someone is sort of perimenarchal and has breast bud development but hasn't yet menstruated, that's where it's a little bit more tricky. But mostly I would say the age of ascent. So many of you would probably know this better than me, but sort of the 8 to 12 range when kids are starting to be able to make their own decision, obviously with the guidance of their parents and the parents' consent. I think that's kind of a coincident age range where a lot of kids, depending on their maturity level, whether they're 11 or 14, they might be kind of heady enough to say, okay, I want to do this. And in that case, if they felt ready, then I wouldn't necessarily delay it. I would say there is some debate in our field about something called the J-shaped curve of aneuploidy. So aneuploidy being eggs that are released that are chromosomally abnormal, or I describe that to patients as like if you had an instruction book to make a person and you had a book with an extra chapter or a missing chapter. So, big pieces of genetic material that are added or missing. We think it tends to be more common in people under 18, and then again, more common in like the 35 plus range. But the increase under 18 is really relative to, say 20, which is really low. So if there is an increase in aneuploidy for 14 or 15, it's still quite low as it compares to, let's say like a 34, 38, 41-year-old. So not to the point where I would say, oh gosh, these eggs are low quality. But it is just a really interesting physiologic thing that we don't really understand. It seems that the highest quality eggs probably come out in the mid-20s. But no, that's not sort of enough reason in my mind to not freeze eggs if someone's, 10, 11, whatever, if they want to do it.
I think our youngest kid that we've sent has been 12. And that's pretty young for us. I think usually we kind of target 14-ish a little bit because like our REI can admit to their adult hospital if there's an issue at that age, and we've just defaulted to that a little bit. But I'm not opposed, like in the scenario you described, Allison, in the question, like if the family was very motivated and at least wanted to go have a consult, I wouldn't be, opposed. And then I think really the ultimate decision is between them and the REI. So
All right, thanks. The next question is, do you see any role for OTC in survivorship patients? And if so, in what scenarios would you consider recommending OTC?
I mean, we definitely have had some patients. I think that if your AMH level is falling, or if we know you're at a high risk or significantly increased risk based on your risk stratification system, but you were diagnosed at a really young age where pre-pubertal, where you were not allowed to get OTC done or not able to get OTC done. I can see this being a recommendation. I think we struggle with what's the right age. I think that's always our big question. We start having these discussions like around 13, 14, but I think a lot of the patients, most of the patients, I would say we've referred for any kind of OTC or any other, real where they've actually gone through with it. They've been above 16, 17. And so where I think they've had, they really can make their own decisions and have been thinking about this. That being said, I know I've had some parents that are very interested at age 12, 13, but our REI is always a little bit more, they're always a little bit more worried about doing them that young, that it's the same reason as Megan just mentioned, they'd have to be admitted to the adult hospital, and it can be quite a traumatic experience for them. So we are working on trying to get them to stay here at Children's when they get it done, but we haven't done anybody that young. But I do think there is a role. I think our default position has been we refer anyone who's got any kind of considerations or thoughts about fertility. And if we can't answer questions, to our fertility experts, our reproductive endocrinologists, and they've done an amazing job of actually counseling patients. They do video visits and they do things where the patients don't have to go into the office themselves. And that way they get a lot of their questions answered that way.
Okay, thanks. All right, in the same vein, is there any role for sperm banking in the survivorship setting?
I don't know if there's not a role. We don't routinely do it. We offer a lot of semen analysis, but we don't routinely freeze the sperm. I don't think we get it as a common question, but every once in a while, like a very anxious family who's either mostly, I think, anxious about recurrence or something like that and wants to go ahead and bank something, especially if the kid wasn't able to before treatment, they were too young or unsuccessful for some reason. So I don't really know offhand whether we have done it or not, but it's not our standard practice. And we definitely offer semen analysis, but we are not banking a lot of sperm in survivorship.
Yeah, I don't think I've ever been asked either. I was kind of just thinking about that. We do have a lot of questions about semen analysis, which we do, and we've actually, for patients that have sperm banked and then they do a semen analysis and they have normal sperm, a lot of them will opt to get rid of their frozen sperm, so that we've had that come up quite a bit. But I don't believe I've ever had a survivor who's not relapsed or had some other issues want to do sperm banking.
Yeah, I agree with that. It's not something we see much of either. With eggs, the chemotherapy can obviously drastically reduce the number, and then there's also a generally fairly dramatic decline of eggs with age anyhow. And then medications like cyclophosphamide and things can accelerate egg loss even post-therapy by activating the mTOR pathway. And we don't to my knowledge, know of a similar pathway in sperm where basically like once the sperm rebound after chemo, we're not necessarily concerned that there's going to be an accelerated loss of them. Now, male fertility does decrease a little bit every year after the age of 30. And interestingly, the rate of some central nervous system disorders like bipolar disorder, schizophrenia, those go up a very small percent each year after 30. It's a relative increase. And so since the overall prevalence of those disorders is relatively low, even if it goes up a little bit, even when male parents are in their 50s and things, the overall rate of central nervous system disorders associated with age is still fairly low. So in this way, what might illustrate it fairly clearly is we don't have like sort of an industrialized sperm banking sort of thing in the country, whereas we have kind of industrialized egg banking. We don't really think of sperm banking as something that kind of needs to be done in general. Even though it's a very low risk thing to do, it doesn't kind of reach the threshold of it being like something that everybody comes to do. So I think in general, yeah, we probably don't have the same kind of background and need for it for male survivors. But I do totally agree with checking a semen analysis. If it's really low, we do sometimes bank sperm for men who've never had chemo, but just have really, really low sperm counts because, kind of like I mentioned earlier, even women who had low risk gonadotoxic therapy could still have other underlying reproductive biology concerns. And there are certainly men who have gonadal failure over time. And so if we see that their sperm count is really low, like just a few sperm on a semen analysis, for example, trying to freeze them is not a terrible idea since it is so inexpensive in general. And they may run out of sperm for issues that are unrelated to their cancer exposure too.
Do you think if that was the scenario and it was a survivor that had a pre-treatment sample banked, would you still advise that, or you would
Nope.
just
Yeah.
what you have?
If it was really low like that and they had a pre-treatment sample, then I wouldn't advise that. Yeah, I would just go with the pre-treatment sample.
Yeah. I think our tricky thing too is some of our, since we see patients both on the front and the back end on our team, a lot of times, our patients are very young when they bank, and so they only have one or maybe two vials banked. So like, we worry that kind of their options might be more limited even for use in the future. So I think, again, we're still not advising banking and survivorship for the most part, but, we kind of always are thinking of like all of those things and looking at like, oh, what do you have banked? And what does your semen analysis look like now? And so those are just other considerations, I think.
And on that same vein, to whom do you recommend semen analysis post-therapy? Only if the patients are interested, or is there anyone that you would tend to recommend, like in general, based on risk?
We offer it to everybody, but definitely not anybody who's not interested. If they don't want to know, we don't say you should go have a semen analysis. Yeah.
We offer it universally as well. We offer it to all of our patients. And if they're not interested, they're not interested. It's interesting. Most of my patients that want it done, a lot of them had already sperm banked before, and they're more interested if they need to continue paying the fee for their sperm being frozen.
Mm-hmm. I mean, on that note, we are fortunate to have pretty discounted rates at our local REI. So since our rates are very discounted, patients ask that a lot, okay, my semen analysis looks good. I can trash my sperm now. And we're like, it's your decision, but like, you might consider keeping it until your family building is complete. So, I think we try to counsel them, and obviously they make the ultimate decision. But I think that's another thought.
And are your semen analyses tend to be self-pay, or does insurance cover those?
Self-pay.
Self-pay.
So
we have some
charitable funding for it, but not an insurance for the most part.
Yeah, ours are also self-pay.
And then I'm going to ask one other question that was on the list, but kind of in the same vein, is there anyone who you would recommend, and in what scenarios, I guess, would you recommend consideration of TESI for a male survivor? I guess Joe can maybe speak to that. Maybe.
Yeah. So I would say for a survivor, I'd recommend Tessie if they were azospermic, like if they didn't have any sperm on semen analysis. But otherwise, I don't see a role for Tessie really otherwise. Or if they can't ejaculate, like if they have an issue with masturbation or another central nervous system disorder that prevents ejaculation, then that would be another reason to consider a Tessie. But yeah, not something to do routinely unless we can't find sperm.
Right, so those are our pre-submitted questions. We can open it up now to the group. So if anyone has any questions that they would like to ask to our panelists, please unmute yourself and feel free to ask. I'm not sure, I can't see the
There's a few questions
chat.
in the chat, Allison. Do you want me to?
Right.
Yeah.
Yeah, I can't see it for
Okay.
some
Yeah, so
weird.
I'm going to read the first one. It's Stephanie Law. What is your threshold for referral to REI for low AMH in adult patients under 24? Is this like pre-treatment or is this during survivorship?
Survivorship.
Yeah, I have a very low threshold. I'm not gonna lie. Like I think that if there's a low AMH, regardless, I always discuss reproductive endocrinology. And like I said, we've been really lucky. Our reproductive endocrinologist will meet with somebody just via video visit. So if they're interested, we refer almost all of these patients.
So are you using like the 2 as a cutoff? Like, because I know like on the AMH charts, it only goes down to 24. And so, that's what I'm wondering is these pediatric patients that have transitioned to the adult world, at what point are we needing to send them? It seems to vary from provider to provider. So I was just wondering what the consensus was with you all.
Yeah, I refer for, like Joe said, if it's under 1 and it's like not, if it's the numbers are going down, or if there's a precipitous drop from like 2.3 to like 1.9, we refer at that point.
Okay.
I also I don't necessarily have a cutoff if the family is very motivated. I don't say like, well, let's wait and wait, see if your AMH drops. Like if they like know especially if they're higher risk or kind of like on the bubble between, risk categories. I don't like to feel like the gatekeeper, not that that's what anybody's implying, but I'm like, anybody can go see REI if you want to. Like Pinki, they'll do a telemed consult. At least the patient can get like a bigger expanded, version of the information and really understand like what harvesting eggs would be like for them. So I have a really low threshold to offer that, and we offer it to pretty much anybody. And we have low risk patients that take us up on it because they're very concerned and they want to. And to me, it makes more sense in a lot of ways, in a lot of patients to, especially if they're highly motivated, to do it while their AMH is still good. And they might have a better, cycle or have more eggs. They may not need to do it as much, if they're lower risk, but people freeze eggs for all different reasons. And they may have reasons outside of their survivorship history too. So kind of think about all that together.
Yeah, I agree with everybody there. Especially if somebody's in adulthood and they're interested at all to consider freezing their eggs. Lots of non-cancer survivors just walk into our clinic and do that because it's so safe. So it's really common to do now. So no problem to talk to really just about anybody about it. The other aspect to consider socially is even if the patient hasn't had like high risk therapy per se, like some of the social disruptions of being a cancer survivor, maybe it's a little bit less likely to be partnered either immediately or in the long run, financial stressors or other things that might come up. People's family building might be delayed for a number of reasons, whether it's relapse, recurrence, other considerations, delayed in being able to finish college, whatever it was. So there could be lots of social factors in thinking about egg freezing, just because somebody might, even with a pretty good egg count now, not be, planning or actually having a, beginning family building for several years. So yeah, I think the threshold could be really low for that.
Is there
Yeah,
another
I was kind of in the gray area with the people who, are kind of in the 1 to 2 range. And what I do typically is go ahead and, offer them a referral if they're interested. I mean, and like you said, I'm not trying to be a gatekeeper and prohibit anyone, but sometimes you want to give them a little more encouragement,
Yeah, I think sometimes I have like similar conversations year after year with families, and so you can tell it's really important to them. And like I think sometimes by the time I've had like a really in-depth discussion for the third or fourth time, even if the patient is still pretty young, I sometimes say like, do you think you might want like a higher level of information? Like maybe just go and have a consult. It doesn't commit you to anything. Most of the patients with private insurance, their initial consult is covered. And, so it, like, I think sometimes just offering that, not saying like, don't you want to go harvest your eggs? I just say like, do you maybe want to have a bigger conversation? And then, and I get lots of takers on that, I think, when I kind of phrase it that way.
Yeah, I think I use a similar approach for that as well. I think it works really well.
that aligns with what I'm doing. I just want to know because I'm kind of on an island, want to know what other people, do. And it's just good to have that conversation.
All right. I see Olivia has her hand raised and there's a few more questions in the chat. So Olivia, if you want to ask your question.
So Olivia here from Cincinnati Children's. Quick question, Joe. We have a big proton center out here and a lot of women who are just going to get proton only. And so we get a lot of questions around like, all right, so now they've got hypo, we see them in survivorship and they're asking questions to us about, what is that journey going to look like for them? And do they need to freeze eggs? We're like, well, actually your AMH has no reason to be declined. But could you kind of maybe give us some advice on how to speak to those patients when they're ready for that family building? They're on full-blown HRT. I'm trying to encourage them to take their medicine, keep the uterus happy, bones, heart, all the good things. But just kind of how that might look in the future for them.
Yeah, great question. So hypo is kind of tricky to treat from a fertility standpoint. So you're totally right. You're thinking about a circumstance there where the egg count hasn't necessarily been diminished, but the signal from the brain has. And that too could be temporary and kind of rebound, or it could look okay at first and then get worse over years. So like if somebody's had CNS radiation, you got to kind of think about that. It's interestingly still not a bad idea to think about egg freezing because a lot of patients that have hypo end up going on to need IVF anyway. When we give gonadotropin shots to try to stimulate ovulation, it's really tricky because a lot of people, especially young people, so people, let's say under 35 that are doing like trying to basically have timed intercourse and ovulate, the way that we would do that mechanically was we would have them take the same shots as IVF, but at low doses. And with IVF, we often get 10 or 20 eggs out. It depends on the egg count, but it's a lot of eggs. Whereas with timed intercourse and ovulation induction, we want to just get one egg to come out. Because if we get 10 or 20 eggs to release into the fallopian tube, that's a big problem. So what ends up happening is people have often very narrow therapeutic windows, especially thin people. And if we give, let's just call it one of the medicine, nothing happens. If we give two of the medicine, just a ton happens and 10 eggs grow. It's just really hard to find the in-between where we get the goal that we want. So a lot of times it's actually safer to do IVF. And just get a lot of eggs, make a lot of embryos, and have that done outside the body, as opposed to trying to stimulate people's ovaries with gonadotropin shots. That's where we get a lot of our triplet pregnancies and things like that. So really, it's okay to refer people with hypo to us as well, in the context of being a cancer survivor or not, and we can talk to them about that as an option. And I would say from a cost perspective, interestingly, it's not that much cheaper to like sort of pursue hypo fertility treatment without IVF. Because what ends up happening is for us to find the therapeutic window for somebody, it ends up taking weeks, and they're taking these gonadotropin shots, which are expensive. And even if they're at low doses, if the process plays out over 5 weeks of us, starting at a low dose, getting no response, going to a medium dose, getting too high a response, coming back to a little bit lower dose, eventually finding the right response for somebody, It takes a while to figure that out. And then, releasing one egg isn't that great a chance at pregnancy. So they might try that month after month. And I mean, this could be like many, many weeks of very expensive shots. So in some ways, IVF might even be cheaper than trying to go through, when they're later in survivorship and do want to try to conceive, it might be cheaper to do IVF. So you could say, okay, if you're 22 now and you're going to try to conceive at, 37 or something, it might be better to freeze eggs now because it's sort of IVF anyway, and the eggs are better quality. So that's the kind of thing we might talk somebody through, for that kind of situation. But that's a great question.
So helpful. And another quick question just to ask. So if someone is like hypo, but they have a good AMH, like do you guys still code that like infertility so they can still get those benefits with that diagnosis?
Yeah, that would generally be covered under, if they have an infertility benefit, that should fly. Yeah.
Thank you. That is so helpful, Joe. I really appreciate it.
You're welcome.
Is there other questions? Sorry, I cannot see the
Chat.
chat. Yeah.
I can read the next question from Melissa Matson. What is the practice for checking AMH when the patient is on contraception?
Good question.
I could take that one. So AMH isn't supposed to be suppressed by contraceptives, but it kind of is for some people. So I would say that it's basically okay at the outset just to check AMH while on contraceptives. If someone has a low AMH while they're on combined hormonal contraceptive, and what I mean by that is like contraception with estrogen and progesterone, then it's a consideration at least of, is it truly low, or is there suppression that's happening because of things like birth control pills that have estrogen and progesterone, the NuvaRing, which has estrogen and progesterone, certain implants that have estrogen and progesterone. A little bit less worrisome for suppression if it's progesterone only. So if it's like an IUD, if it's an implant in the arm that's progesterone only, I'd be a little bit less less able to link their low AMH to suppression from progesterone only. But it seems that estrogen can do it. So it's okay to do it kind of whenever, if someone's on birth control or not. That's kind of how the test was designed. But in practicality, some people do have a suppression from it. So I would just caution somebody who's been on long-term birth control, like, hey, this might not mean what we think it means. It might not mean your egg count is really low. Of course, it could mean it's really low, especially if somebody's had a reason to be low, like cancer treatment. But there's I guess, a hopefulness that it might not be. And so what we might do then is take them off of the combined contraceptive. And obviously, if they don't want to be pregnant, provide another contraceptive, like a non-hormonal IUD or progesterone-only contraceptive. And kind of usually it's going to take about 1 to 6 months to see the numbers rebound. So we could take a look at that. So where I might think about that is if somebody was like on birth control and their AMH was under 1, think, oh, it's low. Is it the birth control or was it your chemo exposure? Depending on what their circumstances at the time, like we could kind of take a look and see if the egg count could go up. Like if they wanted to freeze eggs, for example, and someone's AMH was really low and they'd been on birth control, I might say, hey, why don't we have you come off this for a few months? Let's just see if it rebounds. If not, we'll freeze eggs anyway. But if it does, we're not certain, but it might kind of behoove us to wait a few months and we might actually get more eggs.
Thank you. That's awesome.
I can read the next question. From Brooke Shervan, how do you assess and incorporate the patient's desire for REI for further fertility evaluation? Values around future parenthood can vary and are often related to risk level, i.e. low risk for infertility but strong desire for biological child and vice versa. Do you have a standard way of discussing this? So I know for our survivorship clinic, we discuss infertility with every patient, regardless of what their stratification system is. That way it's not missed. It's just a standard that we, myself, my nurse practitioner, go through for every single patient. And so we always have this discussion. And I think that for us, if a family member, I think that Megan said this as well, regardless of what their risk stratification was, if they're very interested in learning about their risk for infertility outside of just what we tell them, we refer them to our endocrinologist and they really have a much more in-depth discussion with them. But for us, it's just become a standard of care for every patient, regardless of their risk stratification, that we have that discussion. I don't know, Megan, if you guys do something differently.
No, I think I think a similar approach. We don't, for me at least, it's not like necessarily it's individualized based on, their level of concern. That does vary with risk level.
Next, is there a specific time frame to wait after treatment before beginning to track levels?
We wait
Usually
2 years because that's when they
us
come
too.
to Survivor typically. So sometimes some of our BMT patients, the BMT team gets every lab like under the sun at their 1 year visit. So they get them then, but we just say, okay, we look in a year. Yeah. So even though we know those are very high risk patients, we don't usually still give them 2 years to recover.
Yeah, our threshold usually is for patients that are at least 2 years from the end of their therapy or 5 years from the time of their diagnoses, and so that's what allows you to come into survivorship clinic, and that's usually when we check. We have some providers who do check, like just our BMT patient, our providers for sure, but most people will check at least 2 years after the end of therapy for us.
I do think there's data to say that AMH recovery continues till up to around 2 years off of therapy. So I think that 2 years is a good number in general. I can see the chat now. Okay, let's see. In regard to sperm banking off therapy, would it be beneficial if FSH starts to rise as the patient ages, or just proceed to sperm analysis?
I think I'd probably just proceed to sperm analysis.
Yeah, are you saying if their FSH is getting higher, then would you consider banking the sperm? Is that the question? Versus just knowing what their semen analysis is? I don't, it practically for us, it doesn't matter. I mean, if they have a high FSH, then we say, well, you really need a semen analysis if you want to know. But our practice doesn't really change in terms of banking sperm at that point because usually it's already what it is.
And another question, this is a direct message, but for high-risk young males who haven't had pre-treatment sperm banking, at what age do you recommend semen analysis? I'm guessing what age and also probably how long off of therapy. Is there evidence of dwindling semen quality, i.e. a window of time to bank sperm for these patients?
Yeah, I don't think there's really great evidence about a window of time, though I could be disproven on that. There's not a lot of research about that. So I think it's reasonable to wait until, like, if they didn't bank sperm beforehand, just wait until they're ready to try to conceive and then do a semen analysis at that point.
Yeah, we would still wait 2 years would be our threshold for semen analysis as well if they wanted like just an informative one. Not, again, usually those are older boys, but sometimes they're anxious and they want it sooner. So, but we would not, I mean, they're usually in survivorship by that point. So usually by the time we're speaking to them, if they're interested, we can offer.
The next question is, what is the safest / best time to freeze eggs post chemo?
Ideally, try to wait at least a year. We can freeze eggs as soon as 3 to 4 months post initial chemo. For people that have had like 7 and 3 treatment for AML or things that are kind of like a little bit lower toxicity induction chemos, people have tried to freeze eggs like between induction and things like bone marrow transplant, but it goes really poorly. So in general, waiting at least 3 months, and that really depends on the individual because people's sort of follicular maturation time span varies. So some people can mature eggs from their kind of egg bank within a few months, and some people it takes like a whole year. And what I mean by that is for some people, if we look at say even 7 months, like their ovary hasn't recovered at all. And like Allison said, sometimes it even takes up to 2 years to see recovery. So it kind of depends on the individual. We might be able to get eggs sooner than a year, but in general, I would caution someone that that's a little concerning. We might not get a good response, and the eggs that we do get might have sort of grown up, quote unquote, during the chemo exposure. So we don't know if there's like a higher risk of fetal malformation. If it's been greater than a year since chemo exposure, then it seems to be quite safe to freeze eggs, and there doesn't seem to be an increased risk of fetal malformation. So in summary, I'd say wait a year. If it's necessary to go before a year, I would say I wouldn't be very optimistic at all if it's less than 3 months. If it's between 3 and 12 months, it's sort of gray, and we might get something.
I have a question actually for the group. And then we're actually out of time, so I apologize. But for a survivor who is freezing eggs or embryos, do you routinely have them see cancer genetics if they haven't already seen cancer genetics in the past? And at what time do you or do you discuss that?
Our patients see cancer genetics sort of based on diagnosis, so it kind of depends on if they have a likely to be genetic cancer.
Yeah,
So a
us
lot of them
too.
do, but
Yeah,
Yeah.
our all of our patients, it's based on what cancer they have, that they see cancer genetics. We try to get them seen during diagnosis, but during survivorship, if they were not seen, we make sure that happens. But it's not routine across the board.
Yes, they might just go off indication, and there seems to be a lot of evolution about like who gets tested for what disease, and should we do more testing in young people. I just kind of leave it to the genetic counselors at the initial diagnosis, but I don't usually like sort of mandate or add that if it hasn't been done already.
All right, great. Well, thank you, everyone. If you have any other questions, please don't hesitate to send an email. And we really appreciate for everyone's questions and for tuning in. And thank you again. This will be on YouTube, so very exciting. And happy St. Patrick's Day, everyone. Go drink a green beer or have some fun.
Thanks.
Thank you.